Okay, friends, let's get going for a basic of a diastolic function. In next couple of slides, I would like to emphasize what is this diastolic function is, because that's more important. You should analyze what this diastolic function is. So I'm Dr. Rakesh Gupta, who is going to talk about this particular topic of diastology in clinical practice. In heart failure, what is the most important thing which we are encountering as on today in our clinical practice? We are finding more and more people who are having a normal LV systolic function, but they are in congestive heart failures. And if you look back about 30 years down the line, when we were student in postgraduate of medicine, I'm talking of 1986, maybe 40 years down the line, our boss used to teach something like a modality which is known as hypertension with CHF. And what is this hypertension with CHF is? That's what we are going to look forward to evaluate these people who have a normal LV systolic function, but poor diastolic function or elevated filling pressure, what we call in our practice as on today. Now, let's move on. Look at this patient who is a 72-year-old female. She has got a history of hypertension. And look at her classical features for her echocardiography. She is carrying thickened calcified aortic valve leaflets, thickened AML and PML of mitral valve. And then on top of that, she has a mitral annular calcification, which is extending to posterior mitral valve leaflet. LA appears to be dilated, but normal by body surface area, and she has a concentric left ventricular hypertrophy. Well, if you look at all these features together, this concentric LVH could come from a uncontrolled hypertension or because of these thickened calcified aortic valve leaflets, which is giving rise to atherosclerotic aortic valve. LA dilatation could be because of what? We have no answers. Why this LA is dilated, appears to be dilated, and that's what we are going to study in next couple of minutes. Let's look at the clinical features. Pulse is 80, BP is 170 by 110, JVP is raised, bilateral basal cleft, systolic murmur in mitral and tricuspid area, liver is two finger width palpable, soft and tender, and she has got a mild bilateral pedal edema. So what is the clinical feature of this lady? If you happen to look very carefully, this lady, she is a hypertensive and presently she is in congestive heart failure. Correct? Any questions on this? Let's move further. We looked at a chest X-ray, which was normal. ECG shows ST segment depression with T-wave inversion or inverted comma shape 1 AVL V5 V6. Hematological investigations, they were normal. Biochemical investigations, they were normal. And now, looking at this history, looking at this examination, what we say, whether this patient is in congestive heart failure or not. And if it's in congestive heart failure, how do we say this is in congestive heart failure? Now, this is a classification of congestive heart failure. What is congestive heart failure is? Right-sided congestive heart failure. Correct? There is a pre-capillary congestive heart failure. There is a post-capillary congestive heart failure. Pre-capillary, these words are written wrong over here. This is what is, let me just correct them right in front of you. This is the patient of post-capillary congestive heart failure. What does it mean by? Because of left-sided reduced ejection fraction, LA pressures are built up leading to right-sided heart failure. And here, the right side condition per se has given rise to congestive heart failure, where LV functions are reasonably normal. Is that clear? Now there is a condition where there is a reduced ejection fraction, what we call them as heart failure with reduced ejection fraction, as shown in this condition. But you may have a patient where your LV function is normal, as seen in this particular window, but your LA pressures are elevated, or your LA is as big as this over here, which is known as heart failure with preserved ejection fraction. Now, this is a patient whom we were discussing about. Look, this is left ventricular hypertrophy consisting of the significant left ventricular hypertrophy. And what is the criteria as on today to talk of a left ventricular hypertrophy? LV endocardial thickness is more than 13 millimeters. And that's what we measure in Plaque's window, looking at anterior septum and the posterior wall. And then we have a dilated LA in this patient. And if you look at the ejection fraction of this patient is in 4-chamber, 2-chamber, and 3-chamber view is, it looks to be reasonably normal. I'll stop for a second over here. You can look at the contraction, and I'll say thickening. What Dr. Sanjay Mittal was trying to show is not the contraction of this myocardium. Look at the thickening of this endocardium. And if I allow me, I can really zoom up this picture for all of you to look at this focused. Get rid of this from here. Get rid of this from here. And now look at the thickening of the endocardium. Look what he was talking about: basal septum, mid septum, apical septum. Apical lateral, mid lateral, basal lateral. Look how much thickening is happening. And now you can see almost more than 70% of the area is well visualized in endocardium. One important thing, one person asked, we have a really fuzzled or irregular margin which we cannot see with systole. No, it's not possible. In fact, when we have a systole, we could see a very good margins. When we have a diastole, we can have a poor margins, as you can see in this picture. Look, I'm in systole. I can really look at my margins of the endocardium over here. If I go to diastole, my margins really become blurred. Now look at the septum. I'm looking at very good. Look, I can't see a very good endocardial delineation during diastole. What is the solution? Solution is, take my word, go to 6th intercostal space, ask the patient to take a deep breath and hold it. Once you take a deep breath, what will happen? Whole of the heart will push toward the 6th intercostal space. And you will find a very good window where this sector will contain this apex, and this picture would be seen something like this. Keep your hand steady. Both you are able to record systole and diastole. And today is the era of a digital system. And as you can record at any time, 1, 2, or 3 cycles, depending on you. Moving further, let's look at the systolic function of this picture. And in this picture, the ejection fraction is almost normal. So what's the problem? When ejection fraction is normal, so what is the problem? In 2024, we always look at this strain imaging. Not at your level, I'm saying it again and again. We don't have to look at a strain imaging at your level, but for the completion's sake, I would like to say, we look at a systolic function, the longitudinal strains in patient with hypertensive, to look for any evidence of subclinical LV dysfunction. And as he said, we should have a strain rate of -20 in this subset of populations, so that this is considered as normal LV strain. Here, the strain is average is -19.3, which is reasonably normal to expect for this particular patient. It means to say, patient is hypertensive. Patient has got left ventricular hypertrophy, but on top of that, he does not have even the evidence of LV systolic function, which is normal, both by 2 dimensions echo as well as by strain rate imaging. Now, What is the abnormality? And that's what is the field of talk today. What do we look for? We look for mitral flow pattern across the mitral valve when blood is going from LA to LV. It means we are looking for LV filling pressures. Is the word clear? If I'm looking for a diastolic function, I'm looking for LV filling pressures. If my LV is stiff, my LA filling pressure would be high. My LV filling pressure would be high. If my LV is compliant, soft, as good as of a young person, my LA pressure would be normal. And to assess this LV filling pressure, LA pressure, we use the word diastolic function evaluation. Very simple question. LA pressures, LV filling pressure, LV and diastolic pressure, and means diastolic pressure, LV and diastolic pressure, they are virtually synonymous in your language. How do we evaluate? We evaluate by putting a pulse wave Doppler spectrum at the tip of the mitral valve leaflets and then switch pulse wave, not a continuous wave Doppler. We put a sample volume, the pulse wave, at the tip of the mitral valve leaflet in 4-chamber view or 2-chamber view and 3-chamber view, but majority of time we are putting in 4-chamber. What we look? We look for an E wave and A wave in this diastolic function evaluation. So now this is the game of looking at a mitral flow pattern, looking at the game of pulmonic venous flow pattern, looking at game of a mitral flow propagation velocity. That's all in a tissue Doppler image. So at this point, I hope anybody who has questions to say that, what do you mean by mitral diastolic function, which in terms says that we are looking for LV filling pressures, we are looking for LA pressures, we are looking for LV and diastolic pressure. They're all synonymous. And how do we evaluate this filling pressure? We evaluate by looking at the diastolic function, and that diastolic function can be evaluated by majority of time putting a sample volume at the tip of the mitral valve, evaluation of the pulmonic veins, and evaluation of E prime septal, E prime lateral, then LA volume index and a TR jet velocity. Okay, let's move further. Look, same patient which we were talking about is, here is the annular calcifications, 4-chamber view, and look at a huge dilated LA. I don't say it's a huge dilated LA. I say dilated LA, but to confirm whether it's dilated or not dilated, I have to go to the Plex view to look for AP diameter. Divide by body surface area. If it's more than 22 millimeter per meter square, it is dilated. This is what the mitral Doppler spectral flow in a normal subject. Normally, we have an E wave which is taller, A wave which is smaller, and this ratio can become E smaller, A taller. Or this ratio could be more than E ratio could be more than 2, where say elevated filling pressures. So again, going to come on this spectrum over a period of time. Dr. Sanjay Mittal told you very categorically, showed you a slide where he used a tissue Doppler image. Now, I'm sure like talking of a tissue Doppler imaging at this particular moment would be a little bit high, but nothing wrong about it. We put a tissue Doppler imaging. What is this tissue Doppler imaging? One fine man in one morning, he got up. He said, I'm not going to look at the flow velocity to the valve. I'm going to look at the contraction of this myocardium. And very intelligent person, he employed high flow velocity filters to get a low flow velocity signals of the LV contraction. And let me just explain you what this tissue Doppler imaging in bigger sense before I go to further evaluations. So I'm going to do that for you. So what do? We go to the machine, go to 4-chamber view, and there's a button of TDI in the system. As soon as you push a button of TDI, you will find a Doppler spectrum pattern like this in your TDI machines. So you put a Doppler spectrum, you put a switch on the button, you'll find a pattern of this Doppler flow in your systems. And then you take a pulse wave Doppler spectrum pattern slightly towards an LA side. And what you get this kind of a Doppler spectrum pattern when you freeze this 2D image. Look, there are three important components. Go to four-chamber view, switch on TDI from your machine, take a pulse wave Doppler spectrum pattern, littles towards an atrial side, and then do a pulse wave Doppler and freeze your 2D image. Freeze this 2D image. You get a this Doppler spectrum pattern. Now let's look at the component of this Doppler spectrum pattern in relation with ECG. Now, this is the beginning of QRS complex, correct? The beginning of QRS complex is beginning of systole. So if I go over here, this is beginning of systole, and this is what is known as isovolumic contraction time. So here the systole opened up, but the aortic valve did not open. So this is what is known as where the aortic valve is not opened up, the mitral valve is closed, which is known as isovolumic contraction time. Then came opening of the aortic valve leaflets. And this is what is a systole, a true systole. Now the aortic valve is closed, mitral valve is not opened up. This is isovolumic relaxation time. Now suddenly the mitral valve open. The first initial emptying, which is in tissue Doppler, is known as E prime. Then come diastasis, and then come atrial kick. Right? So it's something like what we see in normal cardiac cycle. In normal cardiac cycle is when aortic valve is closed, the mitral valve is closed, aortic valve is not opened up. This is known as isovolumic contraction time. Then aortic valve opens, it gives a blood, aortic valve open gives a blood into the aorta, and the pressure falls up to the point where the mitral valve is also closed and mitral valve is not opened, aortic valve is closed. This is known as isovolumic relaxation time. Now LA pressures are built up. It gives rise to a flow from LA to LV, which is known as initial emptying or E prime. This is diastasis and this is atrial contraction, and then comes the closure of the mitral. What we look in systolic function is we look at this tissue prime at septal annulus. It should be more than 7 to consider it as normal systolic function. But during diastole, we pick up this early diastolic wave, which is known as E prime wave for septum. And we do the same thing for E prime wave of the lateral wall also, and which we call the E prime wave of the lateral wall. So what we looked at? We looked at first, we looked at mitral flow pattern. Second, we looked at the tissue Doppler imaging at septum and lateral wall. And then finally, we went on to do an LA volume evaluations. How to calculate the LA volume? We go to the 4-chamber view, we go to the 2-chamber view, keep them at a same time. This is maximum at one time when the mitral valve is about to open. When the mitral valve is about to open is systole or diastole? Anybody?
Diastolic.
And systole, beginning of diastole. Go back to this picture again. Aortic valve is closed, mitral valve is not opened up. So end of a systole and a beginning of diastole in between that time interval of isovolumic relaxation time. Correct? So we go to this and look at my LA volume in 4-chamber and 2-chamber. The machine calculates the LA volume absolute value. It divides by body surface area. If you fit in the height and weight, it gives you index LA volume, which is 57.2 mil in meter square in this patient. Then we go and look at a TR jet velocity. And this is what the TR jet velocity, somebody was confused. Not a big rocket sign. Go to 4-chamber view. Go to focused RVRA view. put a Doppler spectrum pattern across the tricuspid tissue. Whatever you get is a TR jet. Add RA pressure to it, you'll get peak pulmonary artery pressure. And peak pulmonary artery pressure multiplied by 0.6 at 2.1, you will get a true mean pulmonary artery pressure. So this is the fifth parameter which we employ in day-to-day practice for evaluation of a diastolic function. What we looked? We looked EA ratio. Then we looked E to E prime average. E to prime average means septum E prime, lateral E prime divided by E wave of the mitral flow pattern, peak TR jet velocity, and LA volume index. And if I put these parameters together with this images, let's say where this images belong to this kind of a pattern of E to E prime. If I have to put this parameter of 1 to 1.3, so 1 to 1.3 will come into where? 1 to 1.23 will come to this parameter, and this parameter is grade 2. Now, where is your E2 prime average value will come? It can come 10 to 14 or more than 14. So let me insert another pocket. So I'll show you what this. So second comes more than 14 over here. That's 22.3. TR jet velocity 3.8. It could be 1, 2 or 3. And LA volume index is increased in both of these things. So at least what we are dealing with grade 2 diastolic dysfunction with raised LA volume index. Is that clear or not clear at this point?
Sir, how to take the average E by E prime ratio?
Very good. This is a value of 134 over here. E wave. This is 119 in this Doppler spectrum pattern. There's no confusion this. Okay. Let's go to the next one. We have a tissue Doppler imaging velocity. Sorry for the interruption. Let me go back this. Give me a second because I think slides have mixed up badly.